want to make sure I have maybe 5–10 minutes at the end to entertain questions. I have no conflicts of interest to disclose. What I want to do in this time that I have with you is to really spend some time differentiating between these two constructs, that is depression and apathy. We'll talk about that as we go through, kind of weave that through the talk. I want to talk about how you can incorporate measures that are appropriate to assess depression in medical populations, which is very different than assessing depression in psychiatric populations. I want to spend some time talking about what apathy looks like, the clinical manifestations, the different syndromes, and the different ways it's been conceptualized, and then spend a bit of time talking about the neuroanatomical substrates of apathy and depression. Not that this area is cleanly carved out or that we have a definitive answer, but I think we do have some information that's helpful. Things I'm going to cover are going to be depression and apathy as constructs, because I think what you'll find is in a clinical setting, these two things tend to be kind of coalesced in an individual patient. And if there's one thing that I think is helpful to do is in your mind have a clear idea about the construct of apathy versus depression. I think it really helps with clinical decision making, with treatment, but sometimes, like I say, with a given patient, those two things are hard to disentangle. I'm going to talk about why we should focus on depression in medical populations and apathy, what the importance of these two conditions are, talking some about depression in medical and neurological populations and how that it looks different maybe and is harder to tease out than in a pure psychiatric population. Again, I'll talk about apathy and what it looks like in clinical populations, assessing both those things, and then again the neuroanatomy, and I'll spend a little time talking about treatment. We don't have silver bullets yet for certainly apathy, but we've got some progress that has been made. So starting with these two things as constructs, the thing to keep in mind, the hallmark of a depressive disorder is that it's a disorder of mood or affect. If that's part of the constellation inherent in a depressive disorder. In contrast, apathy, the hallmark of apathy is a disorder of motivation or goal-directed behavior. So if you keep in mind those two basic constructs, it's easier sometimes to tease out what's going on clinically and also kind of to direct your thinking. So Robert Marin was the first person who really started to write about apathy in some kind of cogent way back in the early 90s. And he came up with a three-dimensional model of apathy that really most people are still adhering to today. So there's one component dimension of emotional responsiveness. That is, events are going on in your environment, and as part of your motivational system, there should be some kind of affective response to those events, good or bad. The second dimension of apathy has to do with goal-directed cognitions. That is, do you have some apparatus in, a neurological apparatus that drives you towards appropriate adaptive goals or not? And then there's finally the behavioral component. Can you initiate, sustain, direct those behaviors in a way that's going to get you towards whatever goal it is you're trying to achieve? So different constructs, different ways of looking at them, but we'll find as we go through that there is some overlap between depression and apathy at both a symptom level and neuroanatomically as well. Okay, so why am I focusing on depression in medical and neurological populations? Reason number one, it is extremely common. If you look at point prevalence of depression in the general population, 6–7%. If you start looking at medical conditions, it's doubles, triples. It's very high in lots of these populations. I've given a few examples here. Diabetes, 11–31%. COPD, asthma, about a quarter of that population has a clinical depression. Cancer, all the way up to 50%. So it's very prevalent. If we look at Alzheimer's disorder and mild cognitive impairment, the most common neuropsychiatric symptoms. It's very prevalent in the general medical population as well as neurological populations. Also, the WHO has shown depression is the most frequent medical disorder and the most disabling medical condition in geriatric patients. So prevalent and has a lot of impact. We know from the research, though, that oftentimes this is under-recognized and sometimes not adequately treated in this medical population. Okay, I'm not going to spend time on this. You folks all know the different criteria for major depression. There's a mood, there's the anhedonia, the vegetative symptoms, energy, et cetera. There's this other component, too, of self-criticism, negative self-view, and then we have concentration and suicidal ideation as components. If you take that model then and try to extrapolate onto a medical population, there's problems that arise. Keep in mind, DSM was developed for a primary psychiatric and not a medical population. And it doesn't really take into account that symptom overlap that we'll be looking at with those medical and neurological populations. So therefore, a lot of the instruments that have been developed in psychiatric populations have adequate sensitivity, but they don't have the specificity that you need when you're dealing with that population. So what am I talking about in terms of symptom overlap? So the big one is the neurovegetative symptoms, right? Both medical and neurological populations, as well as people with a pure depressive disorder, have problems with sleep, appetite, energy, libido. Both populations also have problems with concentration, diminished interest and motivations. So when you look at these symptoms, there are 5 of the 9 symptoms that have some overlap. So what do you do with these populations? We'll talk about specific instruments, but if you're looking at just a general interview or psychiatric interview, you've got to give a lot more weight to those symptoms that have to do with self-criticism, sad mood, et cetera, than you do with the vegetative symptoms. Okay, what are the populations I'm talking about? A general medical population is one in which this problem is pretty ubiquitous. So we know from the research, for example, if you take a clinician, a physician that does just a general interview screen for depression, and you compare that diagnostic impression to a standardized depression scale, that correlation is poor. There's something that's being missed between the clinical interview and a standardized, validated instrument that makes the diagnosis in these populations more problematic. A good example is HIV. You see a lot of these symptom overlaps with the vegetative symptoms of depression, the fatigue, the insomnia, the lack of appetite, the cognitive complaints. So that's one challenge. The other challenge then in these populations is how do you disentangle cognitive complaints that are secondary to depression? I can't concentrate, my memory's shot, I'm just not functioning well, to actually the primary cognitive impairments that are due to a neurological disorder. So you've got to have some way to be able to discriminate those things. So bottom line is you look at these populations and the typical DSM symptom picture just may not apply. So then you're left asking yourself, is this person really depressed? Is this a neurological syndrome that I'm not picking up? Or is it both? Because, of course, they're not mutually exclusive. So let's look at prevalence in some common neurological disorders: stroke, Alzheimer's disease, Parkinson's, Huntington's, HIV/AIDS, MS. You can see that in these populations that the depression is in a significant minority of the population, 30, 40, 50%. I'm going to talk a bit about the prevalence of depression and stroke. It's a controversial area. Robinson and his colleagues have been working on this for about 30 years, and I think we still don't have a clear answer. But there is some evidence that left anterior strokes have a greater incidence of depression in that population. With Alzheimer's, there's an interesting phenomena, too. You typically see depression in the earlier stages of the disease progress and apathy later. And I'm going to get back to TBI, but in both cases, the mechanism is probably the same. That is, in the earlier stages of the Alzheimer's process, awareness is less impaired. People are more understanding and appreciative of their deficits and therefore reacting more. As the disease progresses, awareness decreases, and therefore that reactive depression tends to go away because people are just not aware of their losses. So, but the bottom line is you can see that depression is really prevalent in neurological populations as well as the general medical population. In TBI, there's some things to keep in mind that are particular to this population. Again, depression is really rampant. This is the lifetime incidence of depression in the general population, 20%, point prevalence about 7%. TBI, it's several times more in terms of incidence across the lifespan post-TBI. 30–40% of people with moderate to severe TBI are going to experience a depression. Incidentally, TBI is also a risk factor for other types of psychiatric illness. So in this population, you've got to then discriminate between emotional dysregulation, disinhibition, and what really is a depression. That is it just emotional dysregulation, or is there actually some dysphoria and sadness associated with it? And like I just mentioned, in Alzheimer's, there's this inverse relationship that's kind of informative with these, the relationship between depression and brain injury severity. People with moderate to severe brain injury, as indicated by the initial injury severity, GCS, PTA, et cetera, tend to be less depressed than people who have a less severe brain injury. And again, we think that the awareness of deficits and the appreciation of the losses is probably what's mediating that effect. So again, a high correlation, or rather overlap, between the TBI pure neurological types of symptoms and depressive symptoms. You take non-depressed TBI patients, they've been screened, they don't have a clinical depression, but they report these vegetative symptoms, as we all know clinically: fatigue, frustration, irritability, concentration problems. If you, though, compare within a TBI population those folks with and without depression, you can do some degree of discrimination. Depressed patients tend to have more of the psychological components and those vegetative symptoms. So you can do some parsing out even among that population to try to tease out what's going on. Post-concussive syndrome, I believe, is a very different beast. I believe that post-concussive syndrome really has a lot more to do with a psychological reaction to a perception of loss than it does with a direct neurological component to the depression. I won't get into that here, but I can talk about that maybe after the fact. But I think it's really important that there's probably a very different mechanism going on in a person who's had a concussion and has ongoing depression than somebody with a more moderate to severe TBI. In stroke, looking at another population, again, we see what I showed you graphically before. 30–40% of people post-stroke have a depressive disorder. We know, more importantly, too, that this depression drives functional outcome even over and above the actual neurological deficits due to the stroke. So if you take person A with the stroke, person B with the same type, location of stroke, and person A has a depression, that person's going to have a poor functional outcome, is what the research shows. So it's an important thing to deal with in its own right in the stroke population. It's also associated with more institutional care, depression over and above the actual stroke issues. Again, I'm not going to really get into talking about lesion localization and stroke too much. There's been this idea floating around in the literature since, like I say, probably the late 70s, early 80s about localizing it, and it's really has some mixed evidence. Depression in the dementias now. As I mentioned before, depression rates are very high in dementia. It does, in some ways, relative to TBI, show differently than, for example, in apathy. So in depression, in Alzheimer's patients, you have more anxiety, agitation, irritability. The apathy that you see in Alzheimer's, which I'll talk about, is associated more with disinhibition and aberrant motor behaviors. So if you think about it, apathy really is more kind of a subcortical frontal type of presentation, and those other symptoms go along with that. The other thing to keep in mind, too, that you're probably aware of clinically is if you've got somebody with Alzheimer's who's got cognitive impairments, those impairments will very well mask the depression. They may have an aphasia. They may not be able to really convey what's going on. Their memory issues may not allow them to be a good historian. So there may be a depression that doesn't present itself as the same way as somebody who's cognitively intact. Unfortunately, my read on the literature, and people may have different information, that right now we don't have a good evidence base for use of depressions, antidepressants in dementia. And there's a Cochrane review I cited here. We just, I think, have a paucity of studies at this point in time. So, turning now to assessing depression. These are instruments that have been used for years in psychiatric populations. There's two big categories, one of which are self-report measures, the Beck, the Zung, the Hamilton. The patient gives them. They don't have any real normative validity incorporated in them. Then we've got these longer personality questionnaires that are typically not given in primary medical settings. That's our repertoire, really, that we've been using for years in psychiatric population. The Beck being one of the most frequently used, and it really does break down to these three factors. We've got this negative self-critical factor that items load onto, performance impairment, all the slowness, the problems with psychomotor speed, and then the somatic disturbances. And you can see items load here. So it breaks down pretty well along those lines. Here's the important thing about the Beck. If you look at the Beck, these are the different symptoms. So you've got a number of these: loss of pleasure, agitation, loss of interest, anergia, sleep changes, irritability, appetite, concentration, that really overlap with medical symptoms. It makes the Beck a very problematic instrument to use in these populations. We have now much more appropriate instruments to use if you're trying to screen depression in medical and neurological populations. The PHQ, which is widely used, I think probably a lot of people are familiar with that, has great sensitivity and specificity for these populations. It's been validated in medical populations, not general psychiatric populations. So it's good in that regard too, because it's got some validity for these populations. It's also been validated in cognitively impaired populations. And so it's a good, robust measure that actually kind of assesses in a quick way what we're trying to assess in these populations. There's other measures out there as well. The Chicago Multi-Scale Depression Inventory is longer, but the nice thing about this is, again, it's been validated in hospitalized medical populations, so you're comparing apples with apples. The other nice thing is it breaks it out into mood, negative self-evaluation, and vegetative subscales. So, for example, you get a patient to fill this form out, and if you look at the loading on, for example, negative self-evaluation, and that's high, and vegetative factor is low, you're much more confident in this medical patient that what you've got is a real depression than if the converse is true. They're not showing any self-criticism, but they've got all these vegetative symptoms. It helps in that regard. So Jeff Cummings has the EMPI, which has scales for depression as well. There's apathy scales too, so that's helpful to be able to discriminate between those two things. There's other ones as well. So the other one that really stands out as kind of having the most robust support besides the PHQ is the GDS. Again, really high specificity and sensitivity. It's been shown to be a good instrument for those populations that we're talking about. Okay, moving on to apathy now. So switching gears and talking about apathy as a separate construct. Why am I focusing on apathy now? Same things that we talked about with depression, really. First of all, it's extremely common. So if you look at the slide here, you can see we're talking about significant minorities in virtually all the dementias. And in some cases, like for example, in Alzheimer's, almost by definition, somebody who's in the late stages of Alzheimer's, almost by definition, has to have some degree of apathy as a part of their symptom picture. So across the board, TBI, Parkinson's, Huntington's, stroke, ALS, HIV, they all have in that population significant proportions of people who have an apathy syndrome. So it's common, number one. That's why it's important to focus on. It's also conceptually and clinically challenging. It can co-occur with depression. There's a symptom overlap that we'll discuss. And I think the most important thing, the most single most important thing about this whole topic is that apathy often goes unrecognized in clinical settings. And then finally, you need different treatments for apathy and depression. I'll talk about that a bit towards the end. So again, just looking at the prevalence, we've just gone through this real quickly too. You can see in these different neurological populations, stroke, Alzheimer's, Parkinson's, or again, like with depression, where 30, 40, 50% of those folks have an apathy syndrome. In Alzheimer's, what we see, the picture, as I mentioned before, this is the same thing graphically. Community settings, earlier stages, you see still pretty high rates, 20, 30%. As the disease progresses and people move into clinics or into long-term care settings, it goes way up to basically half or more of the population. And you can see that you can discriminate these apathy scores from general medical population. So here's a little histogram showing the distribution of apathy scores for patients with Parkinson's disease in the black versus osteoarthritis in the white. You know, there's virtually nobody with arthritis who's got scores above the 30s, and the tail of the distribution for Parkinson's goes way out to 60 or so. So there is some discriminant validity for this concept. So it's prevalent. It goes across these different disorders. It's also very clinically important. Okay, there's significant mortality and morbidity that you see with apathy in its own right. We know that it decreases patient quality of life. We know that it increases the burden of care on caregivers. If you take person A with X amount of cognitive impairment, person B with the same cognitive profile, person B has apathy, they will have greater functional impairment than somebody with comparable cognitive compromise. Apathy, almost by definition, is going to have poor treatment response and compliance across any disorder you look at. We know that apathy is a greater driver of functional impairment than depression is alone. Those two together cause even more problems. And we also know that apathy increases caregiver distress, not only caregiver burden in terms of the caregiving, but also the psychological component of the stress that goes along with it. The final thing then is it may have some diagnostic utility. We know, for example, if somebody with MCI comes to your clinic and they present with apathy, they're not depressed, that is a better predictor of progression on to dementia than if they didn't have the apathy. And as I've mentioned before, and I'll say again, we know that apathy is more associated with cognitive dysfunction than even depression is. So apathy, again, just to reinforce the definition, is a simultaneous reduction in goal-related actions, thoughts, and emotional responses. So you need this motivational component to, motivation is an inherent part of executive functioning, right? To initiate behaviors, to sustain those behaviors, to direct them in the appropriate way, and then to stop the behavior when it's no longer appropriate. So apathy then is this diminished goal-directed activity due to an absence or lack of motivation. Stuss tends to focus more on his revision on apathy on this component of initiation. I'll get back to that in a little bit. I think the bottom line is there probably are different dimensions of apathy that, as we'll see, may map on to actual neuroanatomical functional systems. These are Marin's initial criteria. I'm just going to highlight them briefly. Again, the lack of motivation, and then in conjunction with that lack of motivation, you have these different domains. Diminished goal-directed behavior as evidenced by lack of effort or dependency on other people to structure activities. Diminished goal-directed cognition. Are you able to actually start thinking about and problem solving to achieve your goal? That's manifested in lack of interest in learning about things or concern about solving those kinds of problems. And then the diminished concomitants. That is, your affect does not change no matter what's going on in your life, whether your goals are being achieved or not, whether there's good or bad events in your life. Then there's the criteria. This is, as you can see, very DSM-like in its structure. Then you have a criteria that the apathy has to cause either significant distress or impairment, and there's rule-outs and exclusionary criteria. You don't diagnose an apathy syndrome if somebody is sedated, for example. There's been a couple revisions of those initial criteria. There's nothing substantive, really. Those three dimensions that Marin first proposed are still there. Starkstein, however, did talk about having a duration and component, again, making it more like a DSM-type diagnosis. Again, the same thing, the dimensions that Marin had initially are there in Starkenstein's revision as well. Same thing with Robert, same type of criteria, just a little bit of honing. So the fundamental construct that Marin laid out really has been kind of validated and held up as time has gone on. Again, just as you've seen the slide before, just looking at the Beck, you see that there is a factor there of apathy, pure and simple, but there's also these other factors that kind of cloud the diagnostic picture when you're using the Beck. But these are the things that load on apathy if you are using the Beck, these items here, the diminished satisfaction, social interest, decision-making, initiative, the anergia, the lack of, kind of motivational energy. So very much like the instruments I showed you for assessing depression in a medical population, we actually have good freestanding apathy rating scales. I've listed a few here. There's actually about 12 or 14 right now. Marin came out with his back in '91 when he was kind of developing this construct. And there's parallel forms for clinicians, caregivers, and self-report. As you know, probably in a lot of these populations who are neurologically involved, not only do you have problems with apathy, but you also have problems with awareness. So getting self-report of somebody with moderate dementia about their apathy syndromes is not going to be probably your best and most valid measure. So you want to have parallel forms, of course. Jeff Cummings, MPI, also, as I mentioned, has an apathy scale in conjunction with other scales on there. And it's a nice instrument because you can start to break down the constellation of neuropsychiatric symptoms and get a kind of a more global sense of what's going on. So there's plenty of scales out there that have been well validated and are available. So that's measurement. I want to now move on to this thing I've been talking about, and how do you tease apathy apart from depression? In the clinic, it's sometimes hard, but again, conceptually, if you've got a heuristic in mind, sometimes it makes it a bit easier. So let's talk about it at the symptom level. So this is the kind of graphically what I've been talking about. You look at the Venn diagram. There are symptoms that are largely associated only with apathy, some largely associated only with depression, and there's some symptoms that have some overlap in those two populations. Those that overlap with depression and apathy, we've talked about a bit already. Diminished motivation and interest, those vegetative symptoms that we saw with the Beck and with some of the other depression instruments, the fatigue, the hypersomnia, that lack of insight, the concentration, and the appetite and other drive-related decreases. But there are things that are pretty much consistent with apathy and not depression. So if you look at depression, you've got that dysphoria that I've been talking about, the guilt, the self-criticism, the helplessness and hopelessness, okay, associated symptoms of the anxiety, agitation. Apathy is the converse, almost by definition. It's that lack of emotional responsiveness, that difficulty with initiating in multiple domains, and the lack of concern. So in a classically depressed person, oftentimes what you'll see is a huge amount of distress about their situation. That lack of concern, in many people is a characteristic of apathy and not depression. And also you see associated signs as well. In apathy, you will see different patterns of motor behavior and a type of disinhibition that you know is related to frontal systems disruption and is not characteristic of depression. Differing courses, too, between the two. I've already mentioned this before. In Alzheimer's disease, depression usually precedes the onset of the most kind of significant cognitive symptoms. It diminishes as the disease progresses. In contrast with apathy, it starts out right out from the get-go as part and parcel of the disease process, and it just continues to worsen as the disease progresses. These things are dissociable. If you look at studies of Alzheimer's, there is a subpopulation of Alzheimer's that have high levels of apathy and really no depression, and vice versa. So you can see that there's, if you look at the population, you can start to dissociate that. This slide kind of shows the same things too. First of all, we know that if you look at the dementia sample, the apathy scores and dementia scores are not highly correlated. Apathy, that I mentioned before, is just as prevalent or more prevalent than depression. Again, you can see a dissociation. If you take a third of Alzheimer's patients had one but not the other. So they don't co-vary necessarily. As I've talked about before, apathy is much more associated with functional disability than depression is in this population as well. In Parkinson's disease, you can see kind of the same thing. We have these different subpopulations, again, very similar, about a third that have one but not the other. And if you look at HIV, you can see that if you take HIV positive and negative people and give them this apathy rating scale, that there's a real split in the distribution. So something that you can discriminate just by looking at the symptom presentation. We also know, though, that there are cognitive findings that also can help to discriminate these two things. So this is looking at the mini mental status examination in Alzheimer's patients. And what you can see here is that people who have no apathy or depression, who have been diagnosed with Alzheimer's, their mini mentals are in the mid or 20s or so. Depression only is not that different than people without depression. But then you see a big drop when you start to include apathy in the equation, both with and without depression. Scores drop down to the low 20s. HIV, we see what we've seen to some degree with the other populations I've talked about. Depression does not strongly load on cognitive impairment. Conversely, with apathy, it does. So, for example, working memory has been shown to really be driven by apathy. And you can see this here in a paper done by my colleague Steve Castellon. We have the blue bar is HIV positive, low apathy patients, so they do have HIV. And then the purple bar is high apathy HIV patients as well. You can see that the high apathy HIV patients have much slower reaction time than their cohort who have HIV but are low in apathy. This is the same thing now across more different psychological measures. We have memory measures here, motor measures, attention measures, speed of processing. And you can see if you just scan the graph as a whole, the high apathy patients who are HIV positive have much lower scores across the board cognitively than those who have low apathy. Switching now to looking at a bit of the neuroanatomy and neurochemical substrates of apathy and depression. I've talked a bit about this theory that's been out there for a long time about localizing lesions in strokes and their correlation with depression. Robinson's been doing this, like I say, for years, and I think it really hasn't held up well. I'm actually going to talk about that. So the best review to date that I've found is this Carson, which is basically a meta-analysis, 143 studies that they looked at, 48 MATE criteria. The majority of those found no association between stroke location and depression. So I think the jury is really out with regard to the relationship between location of lesion and depression, especially in the stroke population. In apathy, I think we may have a little better neuroanatomical model. So we've talked about these three different dimensions of apathy. As a general model, neuroanatomical foundation is the frontal striatal thalamic cortical dysfunction. Three main subtypes that may map fairly well onto what we know about the 3 or 4 different frontal systems subserving executive functioning. So emotional affective apathy, medial orbital frontal cortex and the subcortical regions that are in the same circuits, the amygdala, limbic territories of the basal ganglia. This is that component I talked about in the beginning, the component of apathy that has to do with the emotional resonance, the emotional kind of reward system that drives goal-directed behavior. Cognitive apathy seems to be more associated with lesions of the dorsolateral prefrontal cortex, and as we know, this is what we're talking about here is planning, goal-directed behavior, problem-solving, that component of apathy where you just can't organize yourself to be able to come up with a plan of action to execute to get a goal-directed behavior in the works. And then this auto-activation apathy where you don't actually have the inherent ability to initiate and get the behavior going with prefrontal lesions, dorsomedial lesions, medial frontal cortex, anterior cingulate, which was, as we know, is really a part of that system of activation to salient parts of the environment. This is just a graphic kind of showing the same thing. This is in frontotemporal dementia. The take-home thing to see from this picture, they took caregiver ratings of people with frontotemporal dementia along different dimensions, apathy, agitation, et cetera, and they came up with principal components here. And what you see here, PC2, PC3, those are the principal components that they took from these behavioral measures that really map onto apathy. And what you see, what correlates most with the atrophy seen on structural imaging is those systems I'm talking about, anterior cingulate, orbital medial frontal, and dorsolateral frontal. So in this study at least, what we're seeing in terms of anatomical atrophy maps on pretty well with what we're thinking about in terms of the functional systems that are involved. I'm going to skip the slide. It kind of shows the same thing as schizophrenia. I haven't really talked about schizophrenia, but schizophrenia is probably one of the psychiatric disorders that has the highest prevalence of apathy. And we see some neuroanatomical correlates of that as well. Let me just go through this real briefly here. These are things we've kind of talked about before. SPECT, functional and PET show the same kind of things with regard to these frontal subcortical systems that are involved with apathy. In HIV, we see apathy ratings are correlated with orbital medial frontal cortex, that same system that I showed you with the FTD. So there is some evidence in some about a neuroanatomical substrate for apathy, much more so, I think, than there is for depression. I want to shift now to talking about treatment. We have two domains that we have some evidence for, pharmacological interventions. There is some evidence that dopaminergic agents as well as psychostimulants have a positive effect in dealing with apathy syndrome. If you take somebody with apathy and depression, these agents really are only helpful for apathy, not depression. They show some modest improvement in those types of things like activation and arousal that seem to be able to mediate goal-directed behavior. Acetylcholinesterase inhibitors also show some effectiveness. Everything else really is a wash. There's no other evidence for other classes of agents that seem to have any impacts. The last point about pharmacological agents, though, what we know for sure is that the dopaminergic agents may provide some benefit. Serotonergic agents don't, and in fact, they may actually increase the apathy. So antidepressants are not, from the research that I've seen, an efficacious drug to use in apathy. And again, one more reason to think about discriminating carefully between apathy and depression in your clinical population. Small studies, no RCTs really. We've got a long ways to go in terms of this. Non-pharmacological treatment, we know that there's some efficacy for therapeutic activities. There's been a systematic review by Broderty and Burns fairly recently. These seem to have some efficacies, these structured kind of programs. Another study done in 2011, the same kinds of things. A structured program of activity and engagement seems to help. And what's most important in that last study, at least, is that there seems to be some carryover across time. So there's 3 studies, at least, that show there's some efficacy for using these types of programs, and direct behavioral interventions seem to be able to help as well. So quick summary, we know that apathy and depression are common in these populations. They have real clinical implications and adverse impact on a number of different kinds of outcomes. Diagnosing depression needs to be given some careful thought in these neurological and medical populations. In those populations, you really got to give a lot more weight to the mood and the self-critical components. The big take-home message really, I think, is that apathy, I think, really is oftentimes unrecognized, underdiagnosed, and undertreated in neurological populations. That's, I think, if there's one thing to take away from this is that. They both seem to have some kind of frontal systems dysfunction. We're teasing that out. I think we've got a long ways to go. You can disentangle them both at a symptom level, also in terms of their cognitive impact, and like I said before, apathy has reliably been shown to have more of a cognitive impact than depression alone. And we do have some evidence, not great evidence, but some studies are looking at whether pharmacological or behavioral interventions can provide some benefit. I'm going to stop it there. For all the references I mentioned, I have PDFs. If people want to contact me, I'm happy to send them articles if they're interested. If not, I'll stop there and maybe take a few questions. I have not come across those studies. No, I haven't seen that, actually. I haven't seen that. No, I have not seen anything in alcohol-related dementias.
I think we're kind of stuck. I mean, like, we don't...
Yeah, you've got to kind of choose your poison, really.
Yeah.
And I didn't really go much into psychiatric populations. That's a whole other ballgame altogether. In a neurological population, I mean, you can obviously see those types of psychotic symptoms in Parkinson's, Huntington's, et cetera. But in a neurological population, probably you're better off trying that approach. You know, but I agree with you. You know, and that's the case in psychiatry. The positive symptoms tend to get more of the attention than the negative symptoms, but they both have big impacts on functioning. You know, but I don't have an answer to that question either. Maybe in 20 years we will.
Apathy. How quickly would you see that would be helping a person?
So I don't prescribe, and there's probably people in the room who can tell me really readily, but with Ritalin, you know, it's kind of fast on, fast off. So you could do like an A/B trial across the course of a week or so, and I think I can get a pretty good sense of whether it's going to be helpful or not. People I know in the audience can probably answer that much better than I can. But I think that, you know, something like Ritalin, you can do a little clinical experiment with that patient within patient's kind of design. Dr. Ross, we've done this all the time, and you can get a pretty quick sense of that. Okay, anything else? Great. Well, thank you for your time.